Hey guys, I'm going today speaking with you guys about the USMLE drugs for pharmacology step one. I'm dividing this into two series because respiratory has a lot of drugs. So the first part, we're going to be speaking about your antihistamine, your anti-tussive drugs, your all your drugs which kind of help hyperemia and kind of pulmonary hypertension drugs. And then next video, we're going to get into details about asthma. Okay. Now, let's come into this video. Now, why am I kind of dividing these two key components? I like having everything systemic. We're speaking now about the respiratory system, which includes your nose, your throat, and your lungs. And now the first thing over here is that you're gonna be basically having like all of your like kind of things that affect the nose and the throat, and then you're going to be kind of having like stuff which is going to be affecting your your pulmonary hypertension over here. So this is going to be kind of the two key components over here. Okay. So what is going to be seen over here? Okay, first of all, H1 blockers are also called antihistamines. They're reversible blockers of H1 histamine receptor. Many function as neutral antagonists or inverse agonists. So neutral antagonist essentially means you're going to get baseline. You block a receptor, you get baseline. And then we get inverse agonist essentially means that you have like imagine this in my hand. So in neutral antagonist basically means that you're basically getting like you're blocking the receptor, you're not necessarily pushing it down, okay? Inverse agonist essentially means like you're kind of this is a receptor, this is my fist is a receptor, but you're kind of bringing it lower than baseline. Now, first generation, right? Your first generation is going to be anything that ends with or name usually contains en or ine, or en or ate. So diphenhydramine, dimenhydrinate, chlorphenhydramine, or doxylamine. And essentially, we're going to have four key drugs. Now, of course, the most common antihistamines is allergies. I'm sure all of us have probably taken antihistamines to decrease allergies because essentially allergy is basically allergen enters our body and our mast cells react to it, release histamine. However, what antihistamines does is it decreases histamine, so that prevents any sort of histamine. Of course, leads to vasodilation, it leads to congestion and other effects. And essentially, these drugs decrease your amount of histamine, so they decrease allergies. The next thing is going to be motion sickness and vomiting in pregnancy. Now, I want you guys to know for two things about first generation antihistamines. One, they cross the blood-brain barrier, and two, they have other effects apart from blocking antihistamine 1 receptors. So, for example, motion sickness or vomiting in pregnancy are very similar. Uh, your antihistamines will block your muscarinic receptors. Your antihistamine will block your muscarinic receptors. So you do have your vomiting zones, such as the area prostrema in the medulla, in the vestibular nuclei, H1, M1, your chemo trigger zones over here. You're going to be blocking those. Your motion six is vestibular inner circle, inner ear involved in the balance motion, stimulates the vestibular nuclei, and signals travels to the vomiting center in medulla, and it blocks the H1 muscarinic 1 receptors. Second thing is going to be a sleep aid. Your H1 receptors, it will block it will cross the blood-brain barrier. So therefore, it can cause drowsiness. So it can be used for a sleep aid. Adverse effects, of course, it can go with the blood-brain barrier, so it causes your sedation. And your other adverse effects is antimuscarinic, anti-adrenergic. So, of course, as I mentioned, first generation antihistamines have other effects apart from blocking histamine receptor. So they do block your muscarinic receptor. They do block your alpha 1 receptor. So of course, if you're blocking your alpha 1 receptor, you're going to get hypertension. If you block your anti-muscarinic receptor, you're going to get, of course, like you're going to prevent vomiting, or maybe you're going to get other, like you're going to get maybe some other constipation or urinary retention. You're going to get other effects. Let's come into the second generation. Loratadine, fexofenadine, desloratadine, cetirizine. Now, these usually end with the 18, cetirizine second generation. This is going to be it's going to be used for allergy. Adverse effects far less sedating than the first generation because they have less entry into the CNS. They're basically the same drug as first generation, just you don't have any sedation problems, okay, and much less side effects. So we're gonna take we take second generation. So loratadine, desloratadine, cetirizine, we take second generation all the time. I have like maybe a few pills in my home right now. Dextromethorphan. This is antitussive. It antagonizes NMDA glutamate receptor. However, it has effects. It's a synthetic codeine analog. It has mild opioid effects when used in excess. Naloxone or Narcan can be used when given in overdose. And because it is a codeine analog, it has potential of being abused. and may cause serotonin syndrome when combined with other serotonergic receptors. Now, let's why like what's the relationship between dextromethorphan and opioids or codeine? Dextromethorphan is chemically referred to like codeine and morphine, allowing it to bind to the opioid receptors. Dextromethorphan itself does not bind with high affinity to mu opioid receptors, but it is very similar to opioids structurally speaking. Dextromethorphan prevents uptake, so it's going to be leading to more amount of serotonin, leads to serotonic syndrome. Now let's come to pseudoephedrine, phenylephrine. Mm. Activation of alpha-1 adrenergic receptors in nasal mucosa, local vasoconstriction. So these are going to be causing the reduced hyperemia, used as nasal decongestion, opens the obstructive eustachian tubes. Adverse effects is going to be hypertension, rebound congestion, rhinitis medicamentosa if used more than 4 to 6 days, associated with tachyphylaxis. So what is tachyphylaxis? Like tachy means fast, phylax. What does it mean? It means a rapidly diminishing response to successive doses of drugs, rendering it less effective. The effect is common with drugs acting on a nervous system. You can also use CNS stimulation, anxiety, pseudoephedrine. So that's going to be seen over here. Rapidly diminish response, successive doses of drug, rendering it less effective. This effect is common with drugs acting on the nervous system. So okay. We can see pulmonary hypertension drugs over here, endothelin receptor antagonists, so competitively antagonizes endothelin 1 receptors, decrease pulmonary vascular resistance, hepatotoxic, for example, bosentan. We can see phosphodiesterase 5 inhibitors. So it means phosphodiesterase 5 increases cyclic GMP, prolonged vasodilatory effect of nitric oxide. Also used to treat erectile dysfunction, and this is going to be contraindicated when taking other drugs, like nitroglycerin or a nitrate, to reduce the risk of severe hypertension, for example, sildenafil. Prostacyclin and cyclin analogs, prostacyclin I2, prostacyclin, directly vasodilatory, effects on pulmonary and systemic arterial vascular, inhibits platelet aggregation. Its adverse effects, flushing and jaw pain. Epoprostenol, iloprost are two examples. And flushing and jaw pain is very easy to understand. Imagine you're getting too much blood in the jaw. Endothelin receptor antagonist, endothelin 1, it blocks endothelin. And phosphodiesterase IP2, IP3, it blocks that. Nitric oxide, it will block the phosphodiesterase 5, so cyclic GMP to GTP. And it also has some effects on prostacyclin, increases the amount of your cyclic EMP. So you're going to be having a more vasodilation, or you're going to be decreasing vasoconstriction. I want to kind of just recap because we're going to move into a question. Essentially, antihistamines, just remember your first generation, it's going to cross the blood-brain barrier. So you're going to get sedation, you're going to prevent your vomiting and all that. Second generation, much more cooler. Dextromethorphan, it's a good drug. It has a lot of side effects, such as opioid abuse, because it's chemically related to opioids. It can bind to opioid receptors and others, and it can serotonin. Pseudoephedrine, phenylephrine, it's really good. It can cause reduce hypertension, reduce congestion, open the eustachian tube. However, it has side effects. It causes high blood pressure. It can cause rebound congestion, cause stimulation. Pulmonary hypertension drugs are like antihypertension drugs. You're gonna block endothelin, phosphodiesterase. You're gonna like increase your nitric oxide. Prostacyclin analogs are going to be there for inhibit platelet aggregation. Okay, let's come into a question. A 32-year-old woman with history of idiopathic pulmonary arterial hypertension presents with nasal congestion and cough for 3 days. She purchases an over-the-counter cold medication. Shortly afterwards, she develops a worsening dyspnea, headache, flushing, and hypotension. Her current medications include bosentan, sildenafil. Which of the following components in the cold medication is most likely responsible for her symptoms? The dextromethorphan is a wrong answer because we spoke dextromethorphan is antitussive. There is nothing mentioned about cough, so that's a wrong answer. Okay. Diphenhydramine is a first generation antihistamine. Recall that's just crossing the blood-brain barrier, sedation. So that's out. Phenylephrine. Now this causes what? It was an alpha 1 agonist. So it of course decreases your hyperemia, decreases congestion, decreases your eustachian tube, but it increases your blood pressure. So look, let's read. She has idiopathic pulmonary hypertension, presenting with nasal cough and congestion for 3 days. She purchased over-the-counter pseudoephedrine or phenylephrine. She probably ingested it into her nose. Then she develops high blood pressure, headache, flushing, hypotension, and her current medication of bosentan sildenafil. So now she took that and she's getting a lot of high blood pressure. Okay, pseudoephedrine. This is going to be a wrong answer, and we're going to speak more about that why in the next page. And loratadine, it's going to be a second generation antihistamine and has nothing to do with the question. Okay, let's come over here into the next correct answer is phenylephrine. Let's come over here. Yes. Okay, explanation. The drug integrates so basically we're here the patient has hypertension. So she's taking two drugs, bosentan, which antagonize endothelin receptors, and sildenafil, which increases your cyclic GMP. Excuse me, increases nitric oxide. Phenylephrine is a culprit. Alpha 1 agonist, systemic vasoconstriction, increase afterload, decrease cardiac output. And of course, if you increase the amount of systemic vascular resistance, you're going to get right heart problems. So you can get dyspnea, JVD, flushing, hypertension. And now we kind of spoke about everything. One thing was we didn't speak about the pseudoephedrine. The pseudoephedrine has both mixed alpha 1 and beta agonists. So it causes vasoconstriction but less selective phenylephrine. So it's more likely to cause hypertension and tachycardia than hypertension because that's mixed. And we didn't kind of speak about this. So this is a bit of a tricky question. And this is generated by ChatGPT. So you know its limitation. But yeah, that's about it for respiratory drugs, part one. And I hope to thank you guys for watching. And I hope to see you guys in the next part two.